Hello everyone. So we are going to do clinical cases for Mrcpch Fop, and basically we are doing respiratory disorders. We just finished a respiratory disorders administrator textbook of pediatrics. Now we're doing clinical cases, and some of you were saying that we should like discuss it, and it got very chaotic. Like nobody was hearing anything. So what we're gonna do is we're gonna just review the question, and then we can discuss this on Telegram, or we can discuss over WhatsApp, whatever you people like. First, we will do this. We will wait for a while, and then we go to the explanation, and then we see what it is. You just guess your answers in your head or whatever. So that is more appropriate. And for people who cannot join right now, they can see the uh, video later. You guys can upload it on Telegram as well. So that will be much better. The clinical cases I think there are 6 questions in it for FOP. The first one is chapter 5, a noisy 3-year-old. You're on a call and are called to the emergency department to view Jazz, an 18-month-old boy. When you arrive, he's sitting up in bed, breathing noisily with an occasional harsh cough. His mother tells you that he has been unwell for the last few days with a cough, hasn't eaten much, and has not been keen to play. So he's unwell and he's not eating and he has occasional harsh cough and he's sitting up in bed. These are the key points, and Jazz is reluctant to interact with you, but when he does talk to his mother, you notice his voice is hoarse. Hoarse voice. So just put the key points. We're not discussing it, we're just reading it, okay? So we'll discuss this later. The key points, you guys can send me whatever you guys like. His temperature is 37.7 degrees Celsius, high rate, 105 per minute, respiratory rate 41 per minute, oxygen sats are 96 in air. On examinations, using his accessory muscle to breathe and has harsh transmitted sound inspiratory and no wheeze or crackles. Cardiovascular examination, normal escape refill time is 2 seconds centrally. And which organs the most likely cause of presentation? Bacterium, Haemophilus influenza, parainfluenza, RSV, and strep pneumoniae. And which of the following is the mainstay of management in this case? IV cephalosporin, IV fluids, nebulized adrenaline, oral steroids, and urgent bronchoscopy. And which of the following investigation should be undertaken? Blood samples for blood count, your electrolytes. B is frontal neck X-ray. C is MRI neck, and D is no midget investigation and throat swabs. We can pause it for a while. You guys can like think about these, and then we'll move on. It's just going to be 5 seconds. So the answer is for the diagnosis is parainfluenza, for the treatment, management, so the steroids, and the investigation to be done is no major investigation necessary. So medicine strider of any cause will be based upon the emergency assessment principle of ABC. Pediatrician and emergency general physician should have a low threshold for referral and escalation to the colleagues in anesthetic. Critical care and ENT surgery examination of mouth airway should be avoided without the presence of an airway competent doctor. So as to avoid distressing the children, irritating airway, and risking complete obstruction Jazz is most likely to have croup, which is laryngotracheobronchitis. Croup is a diagnosis made clinically classical features, including onsets of symptoms over 24 to 72 hours, a harsh barking cough, stridor, and a hoarse voice. Importantly, the child does not have features of some of the more worrying diagnoses, drooling, toxic and unwell appearance. He's fine, he's sitting, and as outlined in boxes 1 and 2, croup is commonly caused by parainfluenza virus, and influenza A and B, RSV, and rhinovirus can also be integrated. So basically, it's parainfluenza virus. Number one, bacterial infection. Brachial tracheitis can arise secondarily and is acute and potentially life-threatening. And this is usually caused by H. influenza, Staph aureus, and Strep pneumoniae. Number two is immunization has now made severe infective causes of rare, notably epiglottitis and diphtheria. And bacteria, but there must be considered in a differential diagnosis. This is particularly important if there is suspicion that the child may not be up to date with vaccination. Foreign body inhalation remains relatively common and can be life-threatening, but patients will usually present with a history of a witness inhalation event. Sorry, this is particularly important if there is suspicion that the child may not be up to date with vaccination. Foreign body inhalation remains relatively common but can be life-threatening. But patients will usually present with a history of a witness inhalation event and the prominent hoarseness and cough. So basically, all these are ticked out. And so, and the differential diagnosis rider, if it's infective, it's croup, epiglottitis, bacterial tracheitis, retropharyngeal abscess, and diphtheria, inflammatory, anaphylaxis, hereditary angioedema, otherwise foreign body inhalation, tracheomalacia. In the box two, croup or epiglottitis, croup will have 42 to 72 hours of onset, slower onset, and it has a rapid onset. Prominent barking cough, epiglottitis cough is not prominent, not drooling, able to swallow, hoarse voice, drooling, unable to swallow, talk. This is not appear toxic profoundly, and my sick recurring child unwell in this. They had a 47.7, which is 99, which is absolutely okay. Given the pressure fed to the airway, disturbing the child with invasive investigation, needle for blood sampling, throat swab is unwise, as is moving the child around the hospital to obtain imaging. However, there's diagnostic uncertainty and more sinister problems suspected. Then laboratory tests and radiology will be required. Radiopharyngeal abscess, foreign body inhalation, frontal neck X-rays reform the characteristic steeple sign. Narrowing of the subglottal space, such as the lower airway resembles a church steeple, may be seen in croup. Note that the absence of the sign does not rule out the diagnosis of croup. Patient with epiglottitis may have a thickened epiglottis seen on X-ray, while those with a retropharyngeal abscess may have a tissue, soft tissue bulb and posterior wall of where were we? Uh, I forgot. Patient epiglottis may have thickened epiglottis seen on X-ray, while those with the retropharyngeal abscess may have a soft tissue bulge on the posterior wall of the pharynx. Irregular tracheal mucosa, sometimes strands across the lumen can indicate bacterial tracheitis. Right? Recurrent croup, defined as 2 or more episodes in a year, should be viewed as separate clinical entity from viral group and does require investigation for cause. So diagnostic anxiety, we can get an X-ray, radiology, and to differentiate between all these. Then they'll get a steeple sign. In reticularidis, we get a thickened epiglottis, and retrofringent abscess will have a soft tissue wall or posterior wall of pharynx. So in the recurrent group, if atopy is ruled out as possible explanation, direct laryngotracheal bronchoscopy is essential, and as anatomical airway problems are a significant cause of recurrent group, imaging with X-ray, CT, or MR can also help in case of suspected airway compression due to extratracheal mass, tumor, or abscess. Oral glucocorticoids have been shown to relieve symptoms of croup, reduced length of hospital stay, and need for admission. Readmission, dexamethasone may be superior to prednisolone, reducing admission rates, but evidence is conflicting. Oral administration is equally effective when compared to IM nebulized steroids with resinide and has the advantage of causing less distress. The child is unable to swallow, then IM can be used, but the symptom itself may result an alternative, more sinister diagnosis. Nebulized adrenaline can be helpful adjunct to steroids in more severe cases. It's important to be mindful that the short duration of action, which may result in a short-lived improvement to rebound the symptoms, there is also risk of arrhythmia. If superimposed machine such as antibiotics should be considered along with other resuscitation fluids as needed. Humidified air has no role in critical. Evidence for use of Heliox is currently inconclusive. And all of these are the numbers refer to the references they're giving. So if you want to have a better understanding, you can do it. Otherwise, it's not necessary. I saw a few, and I don't think it is for Mrcpch, like the initial things. You guys can see it online. You have to like buy a few of the what do you call it? There are a few references of the books and the papers that they have. But overall, it's not necessary. Management of flu can be guided by assessment of severity using the categories shown in box 3 and strategies in box 4. Determining severity of flu, mild, moderate, and severe. Occasioned by marking cuff, no strider at rest, no mild accessory use, and suprasternal intercostal sessions. Child appears well, eating, drinking, and playing. Moderate frequent marking cuff, some strider at rest, some accessory must be used. Suprasternal child can be decided but reluctantly engage. Severe frequent marking cuff, formal strider at rest, mild difficulty in breathing, suprasternal intercostal sessions, some distress and agitation, progressing lethargic if hypoxic. Box 4 has management strategy for flu, mild, moderate, and severe. If it is mild, oral steroids are given. Oral dexamethasone, educate brains upon signs of specific and to seek further help, discharge home. Moderate oral dexamethasone, observe for improvement or better within approximately 4 hours, treat as mild, discharge home. And if no improvement, consider secondary minor escalation as per severe case. Severe oral dexamethasone, nebulized and budesonide, and oxygen use blow-by technique of holding mask in the face to minimize distress. Admit to hospital, escalate to pediatric ICU if first name. Syllabus mapping, respiratory medicine with ENT. Know the causes of stridor and principles of management. So these were the references for the reading if you guys want to see the numbers are giving with it. So the next one, you guys have, which one is the next one for it? I think it is. Okay, number 10. We quickly go see number 10. It is, yes, number 10. So moving on, chapter 10, will she be asthmatic? Martha is a 4-year-old child who attends a GP with what mom describes as this is the 4th time she has attended the practice in last 9 months. She's 4 years and for past 9 months she has been wheeze, and on each occasion she had coryza symptoms. She has been very breathless while playing, but is alert and active in the clinic. Her temperature is 37.3, normal heart rate 125 per minute, and respiratory rate is 40 beats per minute. She has mild mucosal recession with widespread breath on auscultation and transmitting noises. She has green nasal secretion. Which of the following is the most appropriate management Strategy: inhale dexamethasone, inhale salbutamol, oral telecast, oral prednisolone, and reassurance. Martha's mother want to know if she's likely to develop asthma. Which one of the following things makes them most likely to if she develop asthma? History of allergic reaction to eggs, history of atopic dermatitis, more than 6 wheezing episodes, 12 months, nocturnal cough and wheezing unrelated to coriasis symptoms. Martha returns to clinic 2 years later. She has had admission to hospital over the previous winter for 3 days, requiring oxygen nebulized therapy. She has been diagnosed as having asthma and commenced upon a salbutamol steroid inhaler. Over the past 6 weeks, she has been using her salbutamol inhaler almost every day. Okay. She has had admission to hospital with the previous one for 3 days, requiring oxygen nebulized therapy. She has been diagnosed as having asthma and commenced upon a salbutamol steroid inhaler. Over the past 6 weeks, she's been using every day and missed several days of school because of. What is the next step in her management? A ipratropium inhaler. We showed the step up in the management. Ipratropium inhaler, telecast, and oral steroids, oral theophylline, and salmeterol long-acting lava. So we can stay here or okay, she's not there. We'll stay here. 5 seconds. Okay, so number one, appropriate management will be inhale salbutamol, and B, major clinical features that she's likely to develop. She's 4 years old, she's likely to develop asthma if the history of atopic dermatitis. And what is the mainstay? Because she has returned after 2 years and she has been history in the winter. She has been admitted for 3 days and nebulized therapy and oxygen has been given. And she has been on salbutamol steroid inhaler. Okay. So the third one would be eat salmeterol. It is important to confirm what is meant by wheezing when a parent volunteers this confirmation. Wheeze can be many different noises to parents, including transmitted noise, rattle, stridor, and being breathless. True wheezing in preschool children is however common and occurring in approximately a third of children less than 5 years of age. Two distinct patterns of wheezing are seen in preschool children. Episodic viral wheezing is needed for preschool age children to have around 6 respiratory tract infections per year. Airway inflammation and constriction of the bronchi can result in wheeze. And when these infections cause recurrent episodes of wheeze, this is episodic viral wheeze. In between the viral infection, children are viral. Infants who have had bronchiolitis the first year of their life and most likely to present in their preschool years episodic viral wheeze. First question to ask when managing a child with episodic viral wheeze is whether they need treatment at all. The use of inhaled therapy to treat mild respiratory noises and minimal respiratory distress may be more problematic than the disease. Martha's restlessness and marked wheeze would indicate the need for treatment, which would initially be with a bronchodilator. Metallicus treatment may be started to prevent 25 wheezing episodes, which results in hospital admission. She had for 3 days. Multiple triple wheeze is when a child wheezes not only with upper respiratory tract but also with other triggers such as exercise, exposure to allergens or smoke. Multiple triple wheeze is part of atopic march, which proceeds to eczema, food allergies, related to cows, milk, protein, nuts and eggs, allergic rhinitis, and asthma. In these children, consideration of preventative treatment should be considered with either inhaled corticosteroids or leukotriene receptor, telecast, or children with which are rescuers as well. Multiple triple Bs have a 50% chance of developing asthma. Those with no atopic personal family history are most likely to outgrow their current receptors as the airway enlarge and the immune system matures. Parents often want to know if their preschool child will go on to develop school-age asthma. There are several predictive indices which will be used when answering the question matters mothers asked in section 2. These indices have a high negative predictive value and low positive value. One such index is the asthma predictive index. It can be used for children aged 2 to 5 years with episodes of wheezing during the first 3 years of life. At least one diagnosed by a doctor predicts those more likely to develop asthma if they have one major, at least two minor criteria from the list. Major criteria are parental history of asthma, doctor diagnosed atopic dermatitis, and minor criteria is one major and two minor. Blood eosinophilia more than 4%, wheezing unrelated to colds, doctor diagnosed allergic rhinitis. Asthma is a term to define children presenting with recurrent episodes of wheezing, breathlessness, fluctuating over time, and treatment often in the context of an atopic background. The management of users covered in chapter 28. There are useful tools such as asthma control tests, among others, which help in identifying patients with fully controlled asthma to guide management decisions. Chronic management, sign advised treatment being commenced early to achieve symptoms control and to step down management when control is good. The guideline advises inherent technique, adherence to medications, and elimination of triggers to wheeze should be considered before increasing treatment. Checking inherent technique is particularly relevant to children. Every GP and pediatrician should know how to administer inhaled therapy effectively. Steps: mild intermittent symptoms under 5 years or 5 to 12 years, short acting therapies, which is salbutamol. And regular preventive therapy. Number 2 is initial add-on therapy, and high-dose therapies. And under 5 years, regular inhaled corticosteroids or leukotriene steroid cannot be used. And in 5 to 12 years, it's regular inhaled for preventive therapy. Initial add-on therapy add leukotriene to corticosteroids. Corticosteroids and leukotrienes are added. Under 5 years, add long-acting LABA to enable. If no LABA response, salmeterol, stop LABA and continue to step 3. If improvement in LABA but insufficient control, continue to step 3. Additional add-on therapy increase ICS dose and consider adding LTRA to therapy, and then introduce LABA. If it's not, 5 to 10 years, and if it's under 5 years, we introduce LTRA. And additional add-on therapies are increased ICS dose, and which is minimum in the we discussed it in the last lecture. Consider adding LTRA to therapy, high-dose therapy. Consider trials of increased ICS dose, addition of a throat drug, slow release theophylline, refer for such scales. Continuous frequencies of oral steroids, use daily steroid tablet and lowest dose providing adequate maintain medium dose ICS. Consider other treatments to minimize use of steroid tablets, refer for specialist care. This is sign measurement of chronic asthma. Sign define complete control of asthma as no daytime symptoms, no nighttime awakening due to asthma, no need for rescue medications, and no asthma attack, no limitation on activity, including exercise when relevant, normal function tests in practical terms, FEV1 or PEF more than 18, predicted or best, minimal side effects from medication, and complication of management. Inhaled corticosteroid therapies contain safe and effective children asthma and improves their asthma control more than other treatment options. There is debate as to whether inhaled corticosteroids affect growth, but long-term it is recognized children with asthma receive inhaled steroids to reach average adult height. There was previous controversy surrounding use of LABAs in the under 12 age group. However, on the risk-benefit basis, they are considered safe in children when ICS treatment is continued. Syllabus mapping, it is prosperity with ENT is the same one. Know how to assess and manage children with acute asthma and wheezing plan long-term therapy. Understand the causes of chronic cough. Understand the cause of chronic cough and appropriate investigations. Understand the long-term complication of medications used